All right. So we're about to start our meeting. As you know, today we are going to talk about endoscopic anatomy of the middle ear. This is part two. João is about to join the conference. It's going to be just in 2-3 minutes. Before starting, I would like to remind you that every question, all the questions should be asked at the end of his talk. And next appointment are going to be on Friday. Friday at 3 p.m. We are going to have, there you go. Perfect. Good afternoon. Good. Thank you. So we're already live right now. So anytime you want, we can proceed. Before that, I would like to remind everyone questions should be asked at the end of the presentation from João. And another important thing is that on Friday, we are going to have the other two panels. The first one is dedicated to the American Rhinologic Society Juniors member from the clinic to the OR, different panels, 4 different speakers. And after that, it's going to be 3 p.m. Rome zone time. At 5 p.m., we are going to have the Maestro Paolo Castelnuovo, who's going to talk about the procedures that should be delivered during this pandemic COVID-19 period. So anytime you're ready, we are going to start and proceed with the second part of this amazing journey inside of the middle ear, João. So let's go ahead with your presentation.
Okay, so I will just share my screen here. Just a second.
All right.
Oops.
Try again.
I just put the zoom here. Just a second.
No,
here. No. Share screen. Yes, here, share.
We got
good. Can you see the screen?
Yeah, everything's fine, but you're launching. It seems that okay, right.
So let's go for this other part of the dissection. In the last week, we ended the dissection before we removed completely the ossicular chain. So this week, we are going to remove the ossicular chain to try to see the mastoid antrum and to try to see some mastoid hair cells from the system. And then, if we have time, we go beyond that to the inner ear, to the fundus of the internal auditory canal, just as a demonstration, anatomical demonstration, not a surgical demonstration. So again, we already saw this part of the dissection, which was the elevation of the tympanomeatal flap and looking for some landmarks. This used to be the posterior malleolar ligament. This is the chorda tympani. This is the left side, by the way. Last week, we saw the right side. So this is the left side. This is the malleus here. This is the incus, and this is the stapes, the cochlear promontory, cochleariform process, supratubal recess, and canal of the tensor tympani muscle here. Here is the anterior malleolar ligament. As we can see, the Prusac space is in this region here. This is the epitympanic diaphragm that we call. And as you recall, I talked about the tympanic isthmus, which is a region between the cochleariform process and the encodoustapedial joint. So I'm cutting here to try to elevate completely the malleus from the tympanomeatal flap from the malleus. And here we can have a close-up view at this anterior malleolar ligament, which is a little bit more thick and more superior than the posterior malleolar ligament, which was here in this region here. But just for time, this is the cochleariform process. As you can see, this is the tympanic isthmus. And in this case, we can see a web here closing partially the tympanic isthmus. It's not completely closed because you have this opening here and you have this opening here on the posterior isthmus, but this the space is small here. So if you have kind of edema here or a fibrous tissue here, you can have a closure of the tympanic isthmus, and then you can have those dysventilation syndromes. But now we can go ahead, we can proceed, look at the facial nerve. here the tympanic segment of the facial nerve. This is the ponticulus, as you remember, the superior limit of the sinus tympani. This is sinus tympani. This is subiculum here. We can inspect inside the sinus tympani to see if there is any cholesteatoma during live surgery. All these steps here you can do during live surgery. The inner ear part of the dissection is different because it's more like a surgical, an anatomical demonstration. So we can see here the sinus tympani between the ponticulus and the subiculum. The pyramidoaminescence here, you can see the muscle here, the stapedius tendon here from to the stapes. And then we can go ahead and do a small articotomy. As you remember, all those structures we saw without removing any bone. But now we can remove a little bit of bone. I like to use the curette, but we can use a piezo device. We can use a drill, a small drill. But most of the times when we talk about live surgery, we are going to do this in cholesteatoma surgery. And the cholesteatoma have sometimes already done some of this bone work to you because it erodes the bone. So it can be a little bit easier. You can go from here to the articotomy all the way to the mastoid tip. But I think it's not a clever move to do this inside-out mastoidectomy because you end up losing a lot of time. You just have one hand if you don't have a holder to do this. And of course, at the end, you will need to reconstruct. So my take on cholesteatoma here is when the cholesteatoma goes to, if it's an infiltrative matrix cholesteatoma, if the cholesteatoma goes all the way to the limit of the lateral canal, which is kind of here, if it's infiltrative matrix, sometimes or most of the times you need to do a combined approach, a retroauricular approach, normal mastoidectomy, and then you remove the remaining part of the cholesteatoma and drill to remove the cholesteatoma that infiltrates the bone from the posterior part, from the mastoid. But if the cholesteatoma is a non-infiltrative matrix cholesteatoma, sometimes even a big cholesteatoma, you can remove through this small hole here because you can wash inside and then the cholesteatoma will kind of pop out from the mastoid antrum. And if the antrum is small, it's better. So we are just palpating here and inspecting here the lateral canal, as you can see, tympanic segment of the facial nerve. This is the avidus ad antrum, the region that the entrance of the mastoid antrum. Now we cut the chorda just for this demonstration, and then we will curette a little bit more here just to remove more part of this posterior part, and then we can remove the ossicular chain, remove the incus. I think the incus is too big for us. Maybe in the future, the incus will be smaller, like in 100 million years from now. And the fact that the incus is big, it makes the tympanic isthmus small. So every time you can have like an inflammation, acute inflammation, or a web, a fibrous tissue, or even some kind of embryological remaining, you can have a closing of this tympanic isthmus, and then you can have these ventilations, as I talked last week. So here we can see the facial nerve. I'll just pass here. Yes, the facial nerve, and this is very nice. This image here, I like it very much. So I will pause. This is the stapes here. And this is the cochleariform process. I removed the incus and I did a small articotomy. As you can see, if you remember from last week, this is the cochleariform process, which is like the center of the dissection. So if you go up to the cochleariform process, we can have the region of the geniculate gangle here and the region of the cog here. This is the cog. The cog is the center of gravity, and sometimes it divides the anterior tympanic space from the posterior tympanic space. And then you have avidus ad antrum, and then the antrum over there. This is the lateral canal, and this is the tympanic segment of the facial nerve. So with the endoscope, you can have this very close-up view when you remove the ossicles, of course, and when you have you don't have an incus, for instance. And then we can go inside. This is an angle endoscope. This is a 45-degree endoscope, and then you can go inside and rotate a little bit, and then you can see a little part of the cells here and a little part of the antrum. As much as we remove from this scutum here, from the article region here, as much as we can see inside the antrum. Sometimes we can see the disease, but we cannot remove the disease because the disease, especially infiltrative matrix cholesteatoma, infiltrates the bone, and then you cannot have a cleavage plane between the disease and the bone and the mucosa. So on those cases, most of the times you need to do a combined approach. You clean the middle ear with the endoscope, but then you need to do a combined approach, performing a mastoidectomy to remove that part. So we can go here, and then we can see better the cog, this region here of the cochleariform process. We can see here the region of the tensor fold in a little bit, I think we're going to see. And then this is very nice to understand this anatomy, this 360-degree anatomy of the middle ear cavity, which is, as we talked last week, the birthplace of most inflammatory and infectious conditions in the ear, because most of the conditions, from a tympanic perforation to a cholesteatoma, they all start at the middle ear. They don't start at the mastoid. They happen to be in the mastoid sometimes, especially cholesteatoma, but most of the disease starts at the middle ear. So with endoscopes, we can tackle the disease. See the tensor fold here? This is the area of the tensor fold. So we'll just come back a little bit just to see the area of the tensor fold. Whoops, here. So this is the canal of the muscle, the tensor tympani muscle, cochleariform process. This is the malleus, and this is the tensor fold. In this case here, the tensor fold is a little bit more horizontalized. You can have a very vertical tensor fold sometimes, and then the tensor fold here probably is closed. Most of the humans, they have a closed tensor fold. Maybe 80% of the dissections you will find a closed tensor fold. What that means? It means that the Prusak space is going to be aerated only by the tympanic isthmus and the posterior isthmus. It doesn't have any more clinical configuration to that. But during surgery, we try to open the tensor fold, and we use those kinds of curved instruments, and then we open the tensor fold just to create this another ventilation route. This is kind of doing a maxillary sinus antrostomy, and removing the incus. Of course, you have a very big isthmus here to be ventilated in this middle ear. So this is another video of dissection here. I will pass this video, and then we go to this one. Yes, this one is good. I did this one in Colombia. This one is good. It's the same, but it's the right side, which is the same ear that we did on last week. So just to do this demonstration again, and in Colombia, there was very fresh cadaver. So you can see there is already still blood on the middle. I think if we did a RCP on the patient could be alive again. But of course, you can see the blood cells here, the vessels here, the arteries here, and of course no red blood cells because it's not alive, but it's almost like alive. And you can see the tensor fold here. You can see the region of the eustachian tube over there. The proteiniculus, as you recall, the proteiniculus, which is this bony mark here to the carotid artery here in the protympanum. And then you can see here, see this one is very nice because this is the stapes. And here you have a kind of a double ponticulus. Sometimes the ponticulus can have different configurations. Can be like a bridge, can be a double ponticulus, can be a single ponticulus, can be like a wall, can be absent. So in this case here, you have this ponticulus here and this ponticulus here. And then the sinus tympani, which is this region here, is divided by two. So ponticulus, and then subiculum here, and the sinus tympani here. This is the region of the facial recess here, pyramidal eminence here, posterior crus, anterior crus, round window, oval window niche. So it's very nice to see this endoscopic anatomy of the middle ear to try to understand why someone is having that condition, like since a perforation or a cholesteatoma or a retraction or whatever, to try to see. I always like to inspect the area of the eustachian tube to see if there is any blockage here or any problems over there. The hypotympanic air cells here, it's very nice. The proteiniculus, as you remember, which is this bony crest that directs us for the carotid artery, which is here. So it's very nice to understand this anatomy. And then we can remove the ossicular chain. We can test the ossicular chain and see the reflex here. Can you see? We can test here again, and this is the round window membrane here, and we can see the reflex. As you remember from last week, we can see the fustes here, which is the landmark instead of the reflex here, the landmark for the scala tympani. So it's actually the floor of the scala tympani. So anytime you have doubt during cochlear implantation where to put your electrode, you can try to find the fustes, which is here, and then you find a round window, and then you can put your electrode in the scala tympani, which is the most used scala to put electrodes nowadays. And then we can do the articotomy again. We can see this eptympanic diaphragm here with the ligaments. We can open here the region of the Prusak space. This is the anterior malleolar ligament over here. And then we open here the Prusak space, as you can see. And then we can have the same image that we had last week, no bone removal. I did a small articotomy here, but no incus removal. We can already see a little part of the lateral canal and a little part of the atus adantrum. But in this case, I will remove, this is the tensor fold. See, this is the area of the tensor fold. It's kind of horizontal tensor fold also, but we can open the tensor fold. In this case, I was not using curved instruments because it was like horizontal, and then we can open the tensor fold with the suction. See, we open here the region of the tensor fold. Of course, during live surgery, you have to open it more to create a more space because no one knows if it's going to close again when you open. But now we remove the incus here, and then we can have this very good view of the region of the tympanic space, the posterior tympanic space, the atus adantrum, and then the antrum of the mastoid. When you remove the incus, most of the times you can remove the head of the malleus to inspect the anterior tympanic spaces, because since you don't have incus anymore, you don't need to have the head of the malleus. So again, we can see here the cog, which is here, the region of the cog dividing the supratubal recess of the anterior tympanic space from the posterior tympanic space. I don't know in this case. Here, the facial nerve, the tympanic segment of the facial nerve, the lateral canal, the tegmen here. Sometimes you can see a dehiscent tegmen, and then you can go inside to see more the region with an angle endoscope to see more the region of the see, this is the cog. The cog in this case, I think, is dividing the supratubal recess from the anterior tympanic space. It's not dividing the anterior from the posterior tympanic space. Sometimes this can happen. The cog can divide the supratubal recess from the anterior tympanic space. The way you differentiate the supratubal recess from the eptympanic cells is the supratubal recess has a more smooth mucosa, and the eptympanic cells, they have more like a granulated mucosa. So this is eptympanic space, this is supratubal recess, this is supratubal recess. Smooth, granulated, and cog, dividing the two. And the landmark for the cog is the cochlear-form process, as you can see in this dissection here. The cochlear-form process is here, geniculate ganglia is here, and then the cog is going to be here. In this case, dividing the supratubal recess from the anterior eptympanic space. So if we proceed, this is the supratubal recess again, and this is important. You will see in the next section, because the dura mater of the middle fossa descends here in this way, all the way to the station 2. Now with the 45-degree endoscope, we can go inside and we see the canal, and then we can see the antrum of the mastoid in all its glory, with all the webs over there, and the mastoid tip is going to be over there. So with the 45-degree endoscope, we can see, with the 70-degree endoscope, we can see. But as you progress towards using angle endoscopes, you have to understand that it's more difficult. And sometimes you have to be more experienced. Sometimes we see a very experienced microscopic surgeon that only does microscopic surgery, but he wants to use like a 70-degree scope on his first surgery. This is not going to work out, and then maybe he or she will have some problems. So this is nice to see this anatomy and to understand the anatomy. This is the tensor fold, which was open here. And the tensor fold is that web that can be generated and can be created to close this anterior ventilation route. Most of humans, they have a closed tensorfold. So this ventilation is like an extra ventilation route. So as you can see, we have a very big space here. And since the artichotomy is not so big, this is easy to reconstruct. If you do a big artichotomy, as we can see, we can go all the way from here inside out to the mastoid tip, drilling or using a piezo or using chisels and hammers or using a curette. You can do it, but for me, I take a lot of time. It's not worth it because you take a lot of time to do this. And at the end, you have to reconstruct the same way. And then for me, it's easier to do a retro auricular approach, mastoidectomy, normal mastoidectomy, and go to the antrum to remove if we have disease over there, as we can see. But now we are going beyond because we already saw this anatomy, kind of this anatomy last week. We removed the incus, and as you can see, only removing the incus, you can have a lot of space for this ventilation and to work inside the mastoid antrum. But this is very nice because it's an anatomical demonstration. This is a left ear, and I did this dissection in Chile. It was a very nice dissection. So I will pause here just for us to understand here the anatomy. So this is a left ear. The ossicular chain is completely removed. This is the region of the eustachian tube. So this is anterior, this is posterior, superior, and inferior here. This is the promontory of the cochlea. This is the cochleariform process. This is the tympanic segment of the facial nerve. This is the lateral canal. This is the cog here. And this is the supratubar recess and the tensor tympani muscle canal. Okay, the carotid artery is going to be here. This is the proteiniculus. Okay, so I already removed the stapes. As you can see, the vestibule is open. And I already removed a little bit of the cochlea, the promontory of the cochlea. So we can see scala vestibuli up here that goes all the way to the vestibule, and scala tympani down here that goes all the way to the round window. Okay, so scala tympani, scala vestibuli, scala media here, and then you can see here the vestibule, which is already open. And this is very nice. It's not like a surgical demonstration. It's anatomical, just for us to understand the relation, because we know the anatomy from the middle fossa, we know the anatomy of this region from the retrosigmoid approach, and we know the anatomy from this region from the translab approach. But it's different to see this anatomy from this transcochlear, transpromontory approach. I'm not advocating the surgery, but I am just demonstrating the anatomy because I think it's important, even for us that do translab approach or retrosig approach, it's important to understand this anatomy in this view. They are the same structures, but with a different view. So it's very nice to see. So scala vestibuli, as we can see there, scala tympani, as we can see there, and this is the basal turn of the cochlea, the most outside turn of the cochlea. So the vestibule is open, and then in the vestibule, in the fundus of the vestibule, we have two anatomical regions, which is the spherical recess and the elliptical recess. We're going to see in a bit. And the spherical recess and the elliptical recess, they are points of attachment of the vestibular nerves, the superior vestibular nerve and the inferior vestibular nerve. So the promontory of the cochlea was already open, and now we can see inside. We can have, this is a 3 millimeter endoscope, this is a 0-degree endoscope. So we can have this very close-up view of the cochlea. At this point, we cannot see the organ of Corti, because the endoscope doesn't have this big magnification, but we can see a lot of things. And then we can see the vestibule here. And when we can see this membrane, this is the saccule. The saccule, as we can see, is behind the facial nerve. The facial nerve is here, the tympanic segment of the facial nerve here, and with this point of view, opening the vestibule, we can see the saccule behind and below the region of the tympanic segment of the facial nerve. So the saccule is here. We can see those white dots over there. I joke that they are the otoconias that we can see. So we can curate a little bit more, and then we can see here the vestibule with all its glory. And then we can see here the saccule, the vestibule. Here is the elliptical recess, the spherical recess, vestibular crest here. As you can see, we can already see a nerve here, probably the superior vestibular nerve here, attaching to the elliptical recess, spherical recess, and the opening here of the posterior semicircular canal. So this is the anatomy that we can see: transcanal, transvestibular, endoscopic. So with a 0-degree endoscope, this is not an angle. If we put an angle degree endoscope, we can see already more of this entrance. So sometimes I have a case that cholesteatoma that invaded the vestibule, and then we had to open the vestibule, and then we saw this anatomy. It's a very beautiful anatomy, and I like it very much, the anatomy. I'll pause again. So again, saccule. Oh, and this is completely because I rotated. So anterior is going to be this position, posterior this position, superior this position, and inferior this position. So we have to angulate here. So we see the tympanic segment of the facial nerve, cochleariform process here, saccule, region of the saccule, posterior lateral semicircular canal entrance, spherical recess. This is a nerve here attaching to the spherical recess, probably the superior vestibular nerve, elliptical recess, spherical recess here, and vestibular crest in this position here. So this is the vestibule. And then we can see more of this region. As you recall, I just removed a little bit the stapes and opened the vestibule. And I use the curette. Of course, in real life surgery, you have to use other instruments if you need to do this. Sometimes you have cholesteatoma that invades the vestibule, invades the cochlea. You can do this kind of approach. So again, the saccule, the vestibule, one nerve there, which is attaching here, and the other nerve is over there. But we can proceed with the dissection, and then we can go to the most superior part, to the apical turn of the cochlea. So as you can see, I'm using a drill, small rotations, just to try to open the apical turns, the middle turn and the apical turn of the cochlea to see the modulus. And the modulus I call the Christmas tree, because it reminds a Christmas tree for me. You will see in a bit. So we can see a little bit of the region of the modulus, and then we can use the curette to go to the fundus of the internal auditory canal. So here we already communicated the modulus, the cochlea, with the vest. The vest was here, and then the cochlea was here. So this is the basal turn, middle turn, and apical turn of the cochlea. This is the Christmas tree that I call, and we already have communicated both structures. This bone is kind of a hard bone sometimes because it's supposed to be one of the hardest bones in the human body, but you can remove this bone with the curette. And then you can go here. Here is very nice, this anatomy, because we can see here, oops, let me focus. We can see here very well. Look, basal turn, middle turn, apical turn. This is the vestibule, elliptical recess, spherical recess, insertion of the superior vestibular nerve, insertion of the inferior vestibular nerve, saccule, and then the cochlear nerve is going to be here, and the facial nerve is going to be in this position here. So we're going to see probably the 4 cranial nerves that we have inside the internal auditory canal. We can see the labyrinthine segment of the facial nerve. We already see the tympanic segment, which is here, but we can see the labyrinthine segment. And this region here is called the fundus of the internal auditory canal. Sometimes we see this region, sometimes, or most of the times, we see this region from the retrosigmoid approach when you use the endoscope sometimes to see the fundus, to see if there is tumor, neuroma, for instance, in the fundus of the internal auditory canal. So with the retrosigmoid approach, you go from medial to lateral, and here we are going from lateral to medial. So it's the same anatomy, but with a different view, which I think it's very nice just for us to understand these differences between this anatomy, which is the same structures. So we can curette a little bit more here, and then this is the fundus of the internal auditory canal. We remove that bone. We can already see the modulus here, the cochlear nerve going into the modulus, and then during real life, during real surgery, as we progress to this step, we would already see CSF leak coming out in the middle ear, because we are opening here the fundus of the internal auditory canal. And once we open the fundus, we are already in the internal auditory canal with all the cranial nerves. So we open here, and then we can already see the cochlear. The first nerve that we see is the cochlear nerve going into the modulus. As you recall, the cochlear nerve is anterior inferior. So the cochlear nerve is going to be in this position. Anterior superior is going to be the facial nerve. Superior posterior is going to be the superior vestibular nerve, and inferior posterior is going to be the inferior vestibular nerve. So we can see that, and it's very nice to understand this kind of anatomy sometimes in a different perspective, in a different way. Again, this is not a surgical demonstration. It's an anatomical demonstration just for we to understand the anatomy. Sometimes we do anatomical demonstrations that are not related to surgical procedures, or that we could not do those kinds of surgical procedures, but we just understand the anatomy to see the better possible way. Sometimes I did a dissection from the maxillary sinus to the middle ear using the eustachian tube as a conduit. Of course, this is not a surgical procedure. This is not a surgical dissection. It's just an anatomical demonstration because I wanted to see the relationship of the eustachian tube to the eustachian tube, to the carotid artery. So we can already see here the fundus of the internal auditory canal, and look at this image. This image is very nice. I'll just focus here a little bit and remove here this, yes, pause here. Look at this image. This image is very nice because we can see here the modulus. We can see here the cochlear nerve going inside the modulus. Cochlear nerve is anterior inferior. We can see here the anterior superior part of the internal auditory canal. So this is the facial nerve. We can see here the posterior superior part nerve of the internal auditory canal. So this is the superior vestibular nerve, and the posterior inferior nerve, which is the posterior vestibular nerve, the inferior vestibular nerve. So we can see all four cranial nerves here inside this internal auditory canal. Of course, you can see sometimes you cannot do things or work. That's why I always call this anatomical demonstration, not a surgical demonstration. So you can see all the four cranial nerves, and in a very good way, in a very good demonstration to understand. But it's also nice to see and to understand the relationship of the geniculate gangle and the great petroso superficial nerve to the muscle, to the tensor tympani muscle, and to the eustachian tube. So we're going to see this in a bit to try to understand also this anatomy. So again, the modulus here, I call the Christmas tree because it looks like, for me, like a Christmas tree or like a mushroom, or there are many names that you can call this thing, the modulus, which I think it's a very nice anatomical structure, very beautiful anatomical structure. The cochlear nerve, as you can see, going inside the modulus, facial nerve here, very well seen, superior vestibular nerve and inferior vestibular nerve. All four cranial nerves in this lateral to medial view. Once again, when you go retrosig, we see this, but from medial to lateral. We see this in another perspective. Here we are seeing this lateral to medial in a more direct route, in a more direct space. As you can see, we just open the vestibule and remove the cochlea and opening the fundus of the internal auditory canal. And then this is a 0 degree. If we put an angle degree, he actually can go inside. And there was one specimen that I did one time because it was a big internal auditory canal that we could go all the way to the brainstem from here, just as an anatomical demonstration, not a surgical demonstration. But it's possible to see that anatomy. But now let's try to see another part of the anatomy. So I'll come back here. This is the cochlear process that I'm removing the cochlear process, and I'm opening and elevating the muscle, the tensor tympani muscle, towards the tube, the eustachian tube. Again, just an anatomical demonstration because we are touching a lot the facial nerve here. This is not a surgical demonstration. And I'm going to elevate with the curette, with the posterior part of the curette, this tensor tympani muscle towards the eustachian tube to expose better the region of the geniculate gangle and to try to find the great petroso superficial nerve that runs in the same position and in the same route as the muscle towards the eustachian tube. So we can elevate this muscle. This is not difficult to do, this elevation in a cadaver. You can elevate the muscle from its canal. And once you elevate, you can expose a little bit better the geniculate gangle, the first genu of the facial nerve. So we can see here the tympanic segment of the facial nerve here, and here the region of the geniculate gangle here. As you can see, as I told last week, the geniculate, this is the cochlear process. The geniculate, this is the cog. the geniculate gangle is not going to be superior, right superior to the cochlear-form process. The cochlear-form process is a nice landmark for the region of the geniculate gangle, but the geniculate gangle is a little bit anterior to the cochlear-form process and to the cochlear. So we can elevate that, and then with the small part of the curette, we can follow the canal of the muscle to try to find the great petroso superficial nerve. So we can dissect here the region of the geniculate gangle and try to find the great petroso superficial nerve, which is not a small nerve. We think sometimes it's a very small nerve like the chorda, but no, it's actually a big nerve. Then you can elevate the facial nerve in, again, an anatomical demonstration. You can elevate the facial nerve from its canal, from the tympanic segment canal of the facial nerve. You can elevate to see the facial nerve going inside the internal auditory canal. So it's very nice. You elevate, and then you see here the entrance of the facial nerve towards the internal auditory canal, towards the labyrinthine segment of the facial nerve. The facial nerve makes a very big turn over here. The biggest turn, the biggest genu is the first genu. The second genu is not as acute as this one. So it turns here at the geniculate gangle to go all the way inside to the inner ear. And then you can see curette and a little bit more bone to see the region of the great petroso, the JPS, the great petroso superficial nerve. As we can see, we can already see here a little bit of it. And then we can follow the great petroso superficial nerve all the way. And it follows, it's nice because it follows the same pathway as the canal of the tensor tympani muscle. So can you see here the nerve going here in this direction? And then you can follow all the way the great petroso superficial nerve, geniculate gangle region, facial nerve going, labyrinthine segment of the facial nerve going this way, tympanic segment going this way, and then you can see here very well. I will pause this image here because you can see here the entrance of the facial nerve into the labyrinthine segment, and then the facial nerve the great petroso superficial nerve going in this position, and then it follows the dura of the middle fossa and follows the canal of the tensor tympani muscle. So it's very nice. Can you see here? Very well seen. You can see here geniculate gangle, labyrinthine segment of the facial nerve going here and following here, labyrinthine, and then the great petroso superficial nerve in this position here, following the dura mater of the middle fossa and following the tensor tympani muscle here, which is very, very nice landmark for it. So we can see here, and this is a very difficult image to see in a normal dissection, in a temporal bone dissection. Most of people, they don't look for this, and they have never seen this image of the geniculate gangle and then the tensor fold, and then the great petroso superficial nerve. So again, facial nerve, geniculate gangle, and then great petroso superficial nerve, and then we can go to see the middle fossa, because here, as I told you, the dura comes from here and descends here towards the region of the eustachian tube. So we can see tympanic segment of facial nerve, vestibule here, saccule here, modulus here, cochlear nerve, facial nerve, labyrinthine segment of the facial nerve is going to be in this position here behind this bone, great petroso superficial nerve, and middle fossa dura mater of the middle fossa, lateral canal here. And then we can go inside and inspect all this anatomy and go with a curette or a piezo or a drill and remove a little bit of this bone here with this muscle, with this mucosa. This is the muscle that I didn't put all the way into the eustachian tube, but now we are putting into the eustachian tube. And then we can already see the dura mater here sometimes because it's dehiscent sometimes, or because the bone is too thin in this region that we can see the dura mater. So this is the area that the dura mater is more close to the middle ear. It's not the tegmen tympani, but rather the supratubal recess. And it's very easy to go inside the dura mater over there because you don't need a lot of fancy instruments. Just a curette, sometimes the bone is very, very small, very thin. You can remove that bone and then you can go all the way. So you can see here, we are removing the bone that divides the dura mater from the middle ear, and we can already see the dura mater of the middle fossa here in this position. So it's a very nice anatomical demonstration just for you to understand the relationships between the structures. Because sometimes when we don't know where the structure is, sometimes we can be afraid of doing some procedures because we just don't know. Consider the middle ear as like your living room. If you don't know what is beyond your living room, maybe sometimes you have a door and you are afraid to open the door because you don't know what is behind the door. But once we know what is behind that door, once we know we have like a kitchen behind the door, we can go inside and we can work inside and we can do things inside. So this is the objective of this demonstration. See the dura mater of the middle fossa, and then we can understand the anatomy and the relationships between the middle ear, the inner ear, and the middle fossa. Because we can already understand this anatomy in a very good way. So we can curate a little bit more, remove a little bit more of this bone. We can remove actually all this bone here because sometimes it's not thick. As you progress towards the mastoid antrum, the bone is going to become more thick. The thinner bone is here, close to the eustachian tube. And as you can see, the dura mater goes like this and then descends to the region of the eustachian tube. So tympanic segment of the facial nerve, geniculate gangle once again, great petroso-superficial nerve. This is the dura mater of the middle fossa. The modilus here, the cochlea was open. Facial nerve going in this position here. Can you see labyrinthine segment of the facial nerve? And then goes all the way to geniculate gangle. Superior vestibular nerve, inferior vestibular nerve, cochlear nerve, saccule, lateral canal, adus ad antrum, antrum of the mastoid, and tip of the mastoid. So we can see this whole 360-degree anatomy and what is beyond also the middle ear using the endoscope and using a transcanal. I'm not using a retroauricular approach, by the way, to do this. This is only a transcanal, but cadaveric, of course, a transcanal demonstration, endoscopic demonstration of the middle ear and again, the inner ear. So again, we can see here this anatomy in a very, I'll come back just a second, in a very good way, because I will pause here because we will see a very nice anatomy and it's very nice for us to understand. So I'll pause here. See, this is nice because you can see a lot of things. So this is the cochlear nerve going inside the modilus. This is the modilus. I call the Christmas tree. This is the facial nerve, the labyrinthine segment of the facial nerve. And as you recall, the labyrinthine segment of the facial nerve is the most, I would say, weak segment of the facial nerve. If you touch this segment, you already have some kind of palsy because it's very, very fragile, I'll say like this. This is the superior vestibular nerve going inside here, and this is the inferior vestibular nerve going to the spherical recess and the elliptical recess. The vestibular crest is going to be between them two, dividing them two. So the saccule is going to be here, tympanic segment of the facial nerve here, region of the geniculate gangle and great petroso-superficial nerve going in this position. So can you see the turn that the facial nerve makes here, kind of a 90-degree turn from the labyrinthine segment of the facial nerve to the tympanic segment of the facial nerve, and then goes to this region here for the second geniule and then the mastoid segment of the facial nerve. But the most radical turn is the turn that it makes here at the geniculate gangle region, the first geniule of the facial nerve. So as we progress with this dissection, we can go and see once again in all its glory this 360-degree anatomy. So we can see a lot of things here. We can see the cochlear nerve, facial nerve. This is the fundus of the internal auditory canal, superior vestibular nerve here, elliptical recess, spherical recess, vestibular crest, saccule here, tympanic segment of the facial nerve, second geniule, mastoid segment of facial nerve, lateral canal, facial recess in this region here, region of the sinus tympani here, basal turn of the cochlea, scala tympani, scala vestibuli, scala tympani, scala vestibuli, middle turn, apical turn of the cochlea, canal of the muscle, of the tensor tympani muscle, geniculate gangle and cochlear reform process is here, geniculate gangle is here, great petroso-superficial nerve is going to be in this position. This is the area of the supratuber recess. The area of the cog is going to be in this position here. Middle fossa, dura mater, here, dura mater. Protympanum, hypotympanum. As you can see, it's a whole 360-degree anatomy through the ear canal, endoscopic. I always like to say this. You have the same structures but you have different views. It's the same in the nose. You have the macroscopic anatomy, the microscopic anatomy, and then the endoscopic anatomy. Here you have the same thing. You have the macroscopic anatomy, the microscopic anatomy, and then the endoscopic anatomy. And here you have more things also because you have different approaches. You can have the retrosigmoid approach, which is a different anatomy. You can have a middle fossa approach, which is a different anatomy, same structures, but different views. So you have to make the draw in your head, in your mind, this anatomical knowledge in order to choose, first of all, which route are you going to take when you want to do any kind of procedure that involves any region that you think that it involves. And second, which one is going to be less invasive or best for the patient? I like to say there's no better approach than the other approach, especially to the skull base, to the anterior skull base or to the lateral skull base. The best approach is, first of all, is the one that you know how to do it. Second one is the one that you think is going to be less invasive to the patient, more secure to the patient, and especially more effective. Because it doesn't, the surgery is only important if you completely can solve the problem of the patient. If you don't solve the problem of the patient, you should never do the surgery. Huh? So it's important to understand these concepts that we use. And since we have the endoscopic anatomy nowadays, and the microscopic anatomy and its approach, we can have those combined approaches using the microscope and using the endoscope for both middle ear inflammatory conditions that extends into the mastoid, cholesteatoma as an example, or also other kinds of lesions, including lesions in the middle fossa, including lesions in the facial nerve, or including lesions in the vestibule or in other areas that you can perform. So I think this was the demonstration, Puya, that I wanted to do today, like 40 minutes. And if we have questions, we can answer.
I think that you put it on some massive data in 40 minutes. So more than great. So yeah, we were going probably to have some very few questions, and it might be possible to have part three. I don't know. It's up to you. We can also. I think that do you have any kind of videos for an inspection of the retromastoid area combined with a angle view from directly through the external meatus?
Yes, and I think if we do like the third presentation, we can have also some surgical videos, some live surgery, not live surgery, of course, edited surgery, surgical videos, because we saw already the anatomy, which is the base, the foundation of any surgery, and then we can progress to go to actually real procedures for people to understand that it's not like this. This is good because it doesn't bleed, it doesn't have CSF, this is good. But in real life, it's completely different. And people sometimes see the dissection, think it's easy to do the dissection, and then want to do like a transpromontory approach, and they will see it's not easy. It's not like that. So I think we can do this. We can see more anatomical views of other areas here in the ear, and also some surgical views.
Yeah, I think that by having also a live perspective, which is dictating the position also by preserving some organs. Of course, what you pointed out is that sometimes we have to remove elements inside of the middle ear, which are the ossicular chain, or we can proceed to other steps only if we can remove things. For example, what happened when you move narrow structures? Can be the flow inside of this small vessel be elucidated? What can we see inside of the middle ear when we go through an endoscope? Of course, the thing is that when you're performing any kind of procedures live, or I mean in a patient's, you will see the blood flow. And what happens also if you're touching those structures? So I think that in order to do this, you have to present some practical cases. However, I do think that what you have done until now for presenting cases and anatomical structures in a cadaveric study is essential. So Those teaching material are the basic things by now. Can you imagine? I just want to raise a concern about this. Everything changed during the last 10 years, I guess, in the endoscopic era of the middle ear. We change our field when we approach through the nose with the endoscope, and now we are facing differences by using the endoscope inside of the middle ear, and people are raising concern regarding well, we are always used to do it with a microscope. So my question is this: do you believe that if anyone would like to start with the endoscope should at least have done a proper way by using a microscope or not?
This is the most important question, I think, and I like to answer this in a very good way. I think differently from the nose, the microscope is still going to be used in the ear because it's still necessary. So in order to do endoscopic ear surgery, this is my take. In order to do endoscopic ear surgery, you must have a very good microscopic background. If you don't, this is not going to be good. If you think, no, I know how to use endoscopes because I do some sinus surgery and I want to do now ear surgery, but if you don't have a good microscopic, it's not going to be good because sometimes you're going to need the microscope is a good instrument, and sometimes it's going to be better than endoscope because you have two hands, you have the stereoscopic view, you can go drill the mastoid faster. But the endoscope is a terrific instrument, an amazing instrument that will be a better instrument in certain areas of the middle ear than the microscope. So for me, the best possible surgeon in my mind here is a guy or girl that can deal with the microscope and the endoscope with proficiency. And this is done now because this new generation of ENTs, they have already a good knowledge of the endoscope, but also they have a good knowledge of the microscope. So I think in the next generations of ENT, there is going to be this mix between endoscope and microscope, maybe in the future, as you know, I like the history very much. And then as we see those historical movies of people doing mastoidectomies with chisels and hammers, and we think, oh my God, they were crazy. Maybe 10 years from now, they were talking about robots, and they'll say, oh, those guys that did with endoscopes and microscopes, they were crazy. Now we do with the robots. So everything changes. Medicine is the science of transient truths. What is true today, maybe tomorrow is not true. What is false today, maybe tomorrow is not true. Hippocrates used to say there is only two truths in medicine. First of one is you will be born. In second one, you will die. The other things in the middle can change.
Of course. For those who's interested, if you want, if you go into the YouTube pages and the Facebook pages of Dr. João Flávio Nogueira, you will find the Sinus Autocentro. There's amazing videos, historical videos. I've checked your page, and are beautiful historical videos regarding procedures, surgeries, and also a technical report of a historical maneuver. So it is very essential and useful for the page for the people that would like to get some information from the historical point of view. The last thing that I would like to address before one question, because I want to make sure the people will attend the part 3. It's mandatory. I'm always asking questions from the people at the end of a presentation, but this time I don't want to do it. I do believe that everyone that would be satisfied to have their answers should attend the part 3. But this one I want to address. Do you believe that if we want to do a kind of inspection of inside of the middle ear, for example, checking out if we do have a mobility of the stapes, we can only use an endoscope?
Yes, I think my take on it is when you need to inspect or when you need to do only middle ear work, my take is that the endoscope is a better instrument than the microscope because it's easier to see. You have this close-up view. The only drawback is you only have one hand. But once you had a lot of experience, you can use two instruments with one hand. You can give very delicate moves with just one hand. But if you only want to inspect the middle ear, yes, in my hands, for me, my take, I think the endoscope is a better instrument than the microscope. But if you have disease on the mastoid, if you have disease on the middle cranial fossa or whatever, the microscope is going to be a better instrument than the endoscope. So it's endoscope is a domain of the middle ear, microscope a domain of the mastoid. This is my take. I cannot hear you now.
I'm sorry. Just one thing that I would like to ask. This is the questions. What are the preparation, okay, before approaching to inside of the middle ear to avoid bleeding?
This is good. We can talk on part 3. I have a whole lecture on this anesthesia and how to reduce bleeding on middle ear endoscopic procedures or mastoid procedures. But basically, I think 3 things. I call the surgical related factors, which are you have to have cutting instruments, cutting instruments, because if you have an instrument that doesn't cut, you have to pass like 1, 2, round knife, 3, 4, and then it's going to injure more. The mucosa is going to bleed. So surgical related instruments are this. Second of all, it's patient related factors. So if the patient has high blood pressure, diabetes, whatever, you have to control that and you have to understand that to try to talk to anesthesia. And the third is the anesthesia and the anesthesia techniques. So TIVA, total intravenous anesthesia, is good, elevating the head, the dorsum, and hyperextending the head. Just like in sinus surgery, we can increase the venous return up to 30% and have less bleeding sometimes. Of course, the room temperature, kinds of drugs that you do, and cottonoids. Cottonoids with adrenaline-soaked cottonoids, 100%, they help a lot. But we can talk this on part 3. I think it's going to be better.
Okay, so no more questions. I will not go for questions for until the next week, because next week we are planning to do the part 3. You will have, for the attendees, everyone will have their own information. Just go inside of each one of our social media channel, both from mine, personal mine, or from the association, and even from the one from Dr. João Flávio Nogueira, and you will have all the information. So thank you so much, João. We really gone beyond the middle ear. We reached to a point to expose neural structure, even the dura mater. So something that was unbelievable until 10 years ago. Everything changed. Everything is going faster. Everything is going more clear. And it's just because of the anatomical studies that has been done on cadavers. So thank you so much. I will see everyone for next week. And the last reminder, on Friday, we are going to have 2 panels. The first one is going to be at 3 p.m. We are going to have the American Rhinologic Society juniors who is going to talk the emergency and ENT from the clinic to the OR at 3 p.m. Rome time. And then at 5 p.m. the lecture from Maestro Castelnuovo for COVID-19 procedures in endoscopic skull-based surgery. Thank you, João, for being with us, and I'll see you next week.
Thank you. And this Professor Castelnuovo is unmissable. We have to see it. It's very good.
Of course. Thank you so much. Bye-bye.
Thank you.